Let's talk about the most unfortunate circumstance of one of our maternal patients going into collapse. So let's look at some numbers for maternal deaths over the last 30-ish years. In the year 1900, the US recorded 850 maternal deaths. 1997, Canada recorded 8.3, and then initially in the early 2000s, it went down to 6.1, and now it's back up to about 8 to 9 women a year. 2018 is the last time they done some statistics on this. So that's the earliest or most recent data we have. And just to give you a definition, it is death of a woman while pregnant or within 42 days of the pregnancy ending, whether that be a termination or a delivery of a baby. Doesn't matter the duration of the pregnancy, the site of the pregnancy, but it's due to any cause aggravated by the pregnancy or a direct result of the management. This includes murder, because domestic violence increases in pregnancy. So there is a very large other category, and suicide and murder, homicide are included in this, not from accidental or incidental causes such as a motor vehicle accident. So this number is probably quite a bit higher when we add in accidents of a person that just happens to be pregnant. So when they looked at these numbers, who are the women that tend to pass away as a result of pregnancy? They have a higher BMI, they are older women. Hypertension is huge in this scenario. It's often involving hypertension. They have tended to have assisted reproductive technology, so in vitro fertilization, and substance use. Overall, the person who dies has about 4 risk factors. So it's not just one, it's multiple things that are causing her to be unwell in her life. And then she gets pregnant, and there are aggravating factors within the pregnancy. As well, a growing refugee and immigrant population. And we know that persons of color have generally decreased health when compared to Caucasian people. So we're looking at these women that have multiple risk factors. We're looking at people of color, thinking that there's always a possibility that they could have poor outcomes. So we're always on alert for the combination of multiple risk factors that things could go wrong. So in the maternal population, the causes of maternal collapse, PPH is still huge in our country, more so in developing countries. Sepsis is a big killer among all people, including pregnant people. Cardiogenic would be heart failure situation. Amniotic fluid embolism is pretty rare, but it is almost always lethal. And then we have things like drug overdoses, anaphylaxis. You can die from having a seizure. That is just the reality of having a seizure. And then we look at things like intracranial hemorrhage, like the patient had a stroke from preeclampsia, from hypertension probably. And then there's always the malignant hyperthermia if the patient received either the drug sevoflurane or succinylcholine, and she had a genetic predisposition. So those are the causes of maternal collapse. We want to make sure that we go through our safety checks in our room, that we have suction is functioning. We want a Yonker suction hooked up at the head of the maternal bed. We don't want a suction catheter that goes at the baby head wall. So we want to make sure the suction is working. We want to have some nasal prongs and a simple mask at the head of our bed. So check your baskets. We want to be familiar with the crash cart and make sure it's getting checked. Make sure the drugs are not expired in our drug modules on the crash cart. Want to make sure the portable oxygen tank on the crash cart is at least 50% And we want to make sure that the defibrillator, the test plug, is plugged in and it's doing its self-test daily. Hanging at every nursing desk, there should be an adult Laerdal bag as well as a non-rebreather. Don't forget about the anesthesia boxes that are located around the unit where there's emergency drugs pre-drawn up, and then the location of the 3 crash carts. Please know where those are. So the tricky thing about pregnancy, and most often our women are young and healthy and have very few risk factors. The problem is that normal changes of pregnancy often look like something else could be going on. So for example, shortness of breath is a physiologic change of pregnancy because of the growing fetus taking up space in the abdomen, putting pressure on the diaphragm. Her lung capacity ends up being decreased, and what you see clinically is a chronic shortness of breath. But shortness of breath in the other adult population would be indicative of something going on with that patient, something lung or heart. Unfortunately, we have our pregnant patients that already have shortness of breath, so it can be hard to distinguish what's going on with our patients. So other things that shortness of breath could be telling us, it could be pulmonary edema, a pulmonary embolism, could be pneumonia, some type of heart arrhythmia. If she doesn't have enough red blood cells to transport her oxygen, that could be presenting as shortness of breath. Could be cardiomyopathy of pregnancy, which is a thing. Could be an asthma exacerbation. All these things the patient could develop in pregnancy, as well as her physiologic shortness of breath of pregnancy. So let's talk about, back to med-surg nursing, what determines cardiac function and how is oxygen delivered to the tissues? So if we back it up, there's 2 main ways that oxygen is delivered to the tissues. One of them is the concentration of our oxygen in our blood. The other one is cardiac output, which is the amount of blood pumped by the heart in 1 minute. How well is our heart functioning? Back that up, what determines oxygen saturation? It's our hemoglobin level, which we know our patients lose hemoglobin because they tend to bleed, either internally or externally. And what determines the concentration of oxygen in our blood has to do with, is our airway patent? Is she breathing normally? Maybe she's breathing too fast or too slow. And then what percentage of oxygen is she breathing in? If it's room air is 21%. So airway breathing and percentage of inspired oxygen determines what is the concentration of oxygen in her blood. What determines cardiac output, which is the heart rate times stroke volume formula. It means the amount of blood pumped by the heart in 1 minute. So rate and rhythm, we already talked about heart rate. Usually in our patients, it's way too fast, either because of stress or dehydration or loss of blood volume, fever. You very rarely will see a bradycardic maternal patient. And then stroke volume is determined by how well the heart is working. So we can talk about preload, afterload, and contractility. Basically, is the heart pumping well enough to push oxygenated blood to the rest of the body? And so we'll go through the most common scenarios for our patients. The number 1 would be pulmonary edema and congestive heart failure. So what's happening with pulmonary edema? For some reason, and there's 2 main reasons, there is fluid backing up into the patient's lungs. There is more fluid than the lymphatic system can drain. And then you see the manifestations of congestive heart failure. So if we do 5,000 births a year, we are going to see approximately 5 to 10 patients coming in with pulmonary edema. So it does tend to happen in pregnancy. There are reasons that pulmonary edema would happen in pregnancy. Now, the problem with persons that are pregnant, they are often young and healthy, and they will compensate and they will not show us they're unwell until they're very unwell. So it's not clinically obvious until they're moderate to severe. And this also has to do with the physiologic shortness of breath that is normal in pregnancy that may be hiding other things that are going on. So the first type of pulmonary edema is due to the heart, cardiogenic. So for some reason, the left ventricle primarily, so the left ventricle is responsible for pushing oxygenated blood to the rest of the body. It is not working as well as it should. It's either because there's way too much fluid, or she's having a heart attack or a cardiomyopathy that the heart is sick and unable to pump as well as it should. Then we've got the hypertension picture, what happens to the heart with that. And then confounding factors would be obesity, excessive blood loss, anemia because we've lost hemoglobin, which means we've lost oxygen carrying capacity, and then multiple gestations put extra workload on the heart as well. Non-cardiogenic pulmonary edema, so it's due to something else other than heart failure. It's generally because there is increased pulmonary permeability. So the patient is third spacing everywhere, but specifically the place we do not want her to third space is in the lungs. So if she is third spacing, fluid in the lungs is not good. And the things that cause third spacing into the lungs in our patient population primarily is hypertension. That's why we always have to have our preeclamptic hypertensive HELP syndrome women on strict fluid ins and outs. We can't just accidentally bolus her a liter running on the gravity pump because that would be very harmful to her. We always want to make sure our fluids are on a pump, and she really does not need any IV fluids. Other things that could cause this pulmonary permeability could be she could aspirate. She could aspirate if we're doing a general anesthetic and she's got food in her stomach. She could aspirate as a result of giving her that rapid sequence induction intubation because she needed a stat section. Sepsis is another big one, something we don't think about very often, but we do give a lot of blood products. She could have a blood transfusion reaction. And then there is catastrophically DIC and amniotic fluid embolism. So I know this is a picture of a man, but it does show the clinical picture of what does your typical pulmonary edema look like. So they're short of breath, they're air hungry, they're having a really hard time breathing, and that's when you will often see that they want to be sitting up, they want to be propped up on pillows, or they want to do the tripod effect where they put their elbows on a table because that's the way they seem to get better air in. Obviously crackles and wheezes on auscultation. There may be nausea and vomiting. They probably have edema to their lower extremities. So with this air hunger and not being able to catch your breath comes anxiety, maybe confusion because there's not enough oxygenated blood getting to the brain. Pulmonary edema, also, you will notice the jugular vein distended because it's backing up into that circulation. They may feel fatigued because they're not getting enough oxygen. There's not going to be a lot of urine output because she's third spacing, and you may see sweating, cold, clammy skin, use of accessory muscles to breathe, and then there's fluid in her lungs, so you might see a productive cough and frothy pink sputum. Here's another, just to complete the picture, it's your patient tripoding, trying to get more air in. They probably have edema of the lower extremities and feel like they just can't catch their breath. So what are we going to do for a patient with pulmonary edema? We want to make sure that the uterus is well displaced so her body can fully circulate her blood. We want to drop the foot of the bed, put her in an upright chair position so then there's not as much fluid that the heart has to worry about circulating. We want to keep her oxygen saturations above 95%. If she's coughing up a lot of frothy pink sputum, we may need to suction just in the mouth. We probably want to do an ABG. We want to make sure we're optimizing her chest expansion. So we're going to put pillows behind her back, or we're going to ramp her, or we're going to put her up into full chair position and give her the overbed table to tripod. And then making sure safety that the side rails are up just in case she does collapse. We want to make sure she stays on the bed. Strict ins and outs, so IV fluid on a pump. You need to get your hourly input IV PO order. We want to make sure we're measuring her urine hourly with a urometer. And even though she does have decreased urine output, we do want to check her urine output Q1H, and we do still want her to make 30 mils of urine an hour, because if she doesn't, then we're thinking about that the kidneys are not working properly. So you probably will be asked to administer diuretics. So furosemide or Lasix is the first line, anywhere from 10 to 80 milligrams, and you might see it quite a higher dose because she does have extra weight on board as well as extra blood on board. So she may need more of a medication to have a better effect. We're going to want to do a chest x-ray to see how bad the fluid buildup is. Morphine is typically given for lots of reasons. It would decrease her anxiety. It will vasodilate her arteries. So, you know, if she's having chest pain associated with that, would dilate the coronary arteries for sure. Just generally decreases the cardiac workload. Obviously, we're going to be doing continuous oxygen saturation on this patient and frequent blood pressures. So if she's sick because of a hypertensive disorder, we might also be needing to run hydralazine or labetalol push, or labetalol or hydralazine infusion, possibly putting in an ART line. And we need to keep her on fetal monitoring, because if she's hypoxic, the fetus is hypoxic, and often mom's compensatory mechanisms will be well enough to keep her going for many, many hours to days, but the fetus is the one who does not have reserve and as good of compensatory mechanisms. So the baby will possibly tell us first that he is not well. And then any hypoxic state in the patient may trigger labor. Obviously, we want to treat the underlying cause. Moving on to pulmonary embolism. So this is a statistical fact that pregnant people are at higher risk for having a PE or a DVT, but PE is the super dangerous one. So a clot has formed somewhere, and it has traveled up into the respiratory circulation. And this causes respiratory distress, respiratory failure, all the way up to heart failure. So we know that pregnancy is a state of hypercoagulability. In the third trimester, you are 6 times more likely to have a clot event than in the non-pregnant person. This increases dramatically postpartum. 22-fold increase. The peak of that is in the first 3 weeks postpartum, and it is greater in people who are obese and people who have had a C-section. So you will see those patients on tinzaparin prophylactically to try and prevent the clot. Clots have implications such as post-thrombotic syndrome, and patients who have clots do go on to develop chronic venous insufficiency. So we need to think about health across the lifespan for our patients. So what exactly causes a clot? So let's go back to second-year nursing and talk about Virchow's triad. So you need 3 things to cause a clot. You need stasis. What does that look like in our patients? The baby is laying on the abdominal aorta and the inferior vena cava, so that is causing stasis. When we give a patient a spinal and she's laying on the OR table, that causes stasis. That's also one of the reasons why we generally don't put pregnant people on bed rest anymore, is because she's more likely to develop a clot due to stasis. Then we know that pregnancy is a state of hypercoagulability. The body does make more clotting factors in pregnancy. And then the third thing you need in order to cause a clot is a vessel wall abnormality or injury. And so when do we get vessel wall injuries? During a vaginal delivery, we tear a bunch of tissue down in the vaginal area, or in a C-section, we tear and damage a bunch of tissue by doing the C-section. So you can see how this three-legged stool of Virchow's triad is a very likely opportunity for a clot to present in our pregnant population. Additional risk factors, vacuum forceps, having an infection, having a multiple pregnancy, diabetes, stillbirth, going along the other left-hand side of the column before pregnancy, smoking, age, mechanical heart disease, IV drug use, paraplegia, not very common, even a parity over 3. Then we also have the genetic factors that put our patients at additional risk as well. Signs and symptoms of a pulmonary embolism. So what I need to stress that most of our patients are young, healthy people. In a young, healthy person, tachypnea and tachycardia are never normal. So if your patient is presenting with increased respirations, we need to take a closer look at what's going on. If she has a high pulse, we need to take a closer look at what's going on. Anything after about 103, we need to start thinking about infection, sepsis, PE. Those would be your top. Pleuritic chest pain presents in the patient 72% of the time. So that's pain on inspiration. So that is not normal. And then the less common things like cough. I mean, patients have coughs for various reasons. So we would have to sort out what is the cause of that cough. Bloody sputum, never normal. And then a fever can also present with PE as well. Remember, our patients are young and healthy, and they have excellent compensatory mechanisms. And so these clues are going to be subtle until she reaches a state of total collapse, and then we have a problem. But we need to be looking for these subtle clues and picking up on these things beforehand so that we can prevent the maternal collapse. How do we diagnose PE? So you cannot diagnose a PE on chest x-ray, but we're going to do one anyway because it will help us rule out other things like pneumonia or pulmonary edema. ECG is not going to diagnose a pulmonary embolism, but it will rule out a cardiac arrhythmia or a myocardial infarction, which is also more common in pregnancy. And you read about that in your cardiac complications presentation. We're going to do an ABG just so we have an accurate measurement of her pH, acid base, and oxygenation status. Then a couple imaging procedures. There is a VQ scan, so it doesn't definitively say yes, she has a PE or no, she has a PE. It's going to say low, intermediate, or high. So that's somewhat helpful, not very helpful. And then the spinal CT angiography has a negative predictive value of 99%. So it's 99% accurate to say, no, it's not a PE. But again, that doesn't help us diagnose a PE. So there is no one gold standard definitive test that is going to tell us, yes, she has a PE. So we are going to take the combination of the clinical picture with the imaging and the imaging that we have. What are we going to do to treat a PE? We're going to keep her on oxygen to keep her saturations over 95. We're going to give her analgesia for her pain, possibly her anxiety. We are probably going to start her on a heparin nomogram. She's probably going to get a Dopplers of her legs because we want to check if there's other clots, and pneumatic compression stockings while she's in bed to prevent any further clots from happening. Moving on to the very unfortunate amniotic fluid embolism. So what happens is a little piece of amniotic fluid gets up into maternal circulation. How could that happen? Well, the placenta, the site where the placenta adheres to the uterine wall, that is the interface between mom and baby. That in that location is where a little bit of amniotic fluid could get up into maternal circulation. And so what's in amniotic fluid? There's vernix, hair, all sorts of debris that is extremely irritating to mom's vasculature. And so this piece of irritating substance gets into her circulation and the patient has a dramatic response. Travels rapidly to the right side of the heart and enters cardiopulmonary circulation. If meconium is pregnant, the response is even more dramatic. So 1 in every 15 to 53,000 births. So if we have 5,000 births a year, let's say we maybe have 10,000 births in Saskatchewan a year, we're going to have an amniotic fluid embolism about every 1 to 3 to 5 years. We may not hear about it if it's happened in Regina, PA, other centers. So mortality is very high. It's almost 100%. This is very rare, but very catastrophic. Well, mortality rate is between 11 and 44%, very high in the first hour. The problem is once she has an amniotic fluid embolism, she goes into an anaphylactoid/DIC state. The damage is done because of the body going into that state, not just the act of the amniotic fluid embolism. So leads to shock and an anaphylactoid state because of the massive response of histamines, prostaglandins, all types of hormones that are causing problems for mom. So there's initial pulmonary hypertension, right ventricular failure, then left ventricular failure. So she's in heart failure. Then she goes into multiple organ failure. Then she goes into DIC. So the combination of all these things, multiple organ failure, anaphylactoid state, and coagulopathy, DIC, it can be very, very lethal to the patient. That's why the mortality is so high. So what are your risk factors for AFE? Multiple pregnancies, induction of labor. Again, there's the advanced age, operative delivery, either forceps, vacuum, or C-section, eclampsia, polyhydramnios, lots of things that we do to our patients every day here. Signs and symptoms. There is a sudden, unexplained respiratory distress, total collapse, and then the coagulopathy, so actively bleeding and clotting at the same time. Might present as uterine atony. And then might present as respiratory distress, hypotension, seizure or seizure-like activity, or maybe just a fetal bradycardia. The problem with all these presentations, again, is it could be multiple things. So it could be a PE, could be congestive heart failure, pulmonary edema, like I've just discussed, could be a heart attack, could be septic shock. She could have aspirated, she could have anaphylaxis, or it could be local anesthetic systemic toxicity. Lots of different things that it could be in our patient population. How do we treat it? We treat it with ACLS, massive hemorrhage protocol, deliver the fetus, send her to ICU, and they will look after her.